Hello, my name is Kim Boatman, and I'm going to be going over the Child and Adolescent Trauma Screen, also known as CATS. I will go over the purpose and theoretical foundation of this assessment, as well as discuss the administering and scoring guidelines. I will inform you on the psychometric characteristics, discuss the strengths and limitations, as well as some of the ethical and multicultural considerations. And finally, give you some of my takes on this assessment. The purpose of the CATS is it's a screening to help identify children and adolescents who have or have been exposed to traumatic events. Trauma can be something that they have gone through, a traumatic event that they have witnessed, or an event that has happened to a close family member, such as a parent. Unfortunately, about 40% of all adolescents will experience some form of traumatic event. Not all trauma-related events lead to PTSD or impairment in functioning. However, for those that it does affect, this screening will allow clinicians to detect it earlier and be able to promptly provide services. Previous trauma screenings did not address both the symptomology and experiences, and they were based on the DSM-4. The DSM-5 has made changes to PTSD criteria that extended to exposure of events and symptomology. It also moved PTSD from an anxiety disorder to a trauma and stress disorder. CATS measures both the traumatic experience and the symptoms in youth. In regards to the theoretical foundation, the CATS is based on the PTSD criteria of the DSM-5. And the questions are based on the core domains of the PTSD diagnosis, such as re-experiencing intrusive or involuntary memories, avoidance of reminders, feelings or thoughts from that event, negative mood and cognition changes such as negative beliefs about oneself, or distortions that lead to self-blame, and last, hyperarousal such as irritability or reckless behavior. So although it does not diagnose, it can provide a preliminary PTSD diagnosis to initiate further assessments. Also, the 3 to 6 year old version does conform to the DSM-5 as well for children 6 years and younger. CATS assumes that direct and indirect exposure to traumatic events can lead to PTSD for adolescents. The assessment is broken into 3 sections: exposure, symptomology, and effects on functioning. The trauma-informed care approach highlights that you need to look at the whole picture of the child's life, past and present, and to maintain a culture of safety, integrity, and healing. On this slide is an example of the scoring sheet for a 7 to 17-year-old. The sheet looks exactly the same for a 3 to 6-year-old. However, the wording is simpler so that they can understand. The administration of the CATS is a self-reporting assessment, although it can't be administered during an interview. With children in the 3 to 6 age, it is best to interview as some may not be able to read or grasp the question. For older kids, sometimes they are more comfortable when not having to say their answers out loud. There are 15 questions that assess previous exposure to trauma events. They are yes and no responses to see if they have had any experience in any of the listed scary events. 20 questions that measure PTSD criteria from the DSM-5, and 5 questions related to impairment. This assessment should be considered a clinical encounter, and the clinician is meeting with the client as part of a therapeutic care planning process, and should be prepared to address any triggering events or concerns. It is a very short questionnaire and answers with yes or no, or on the PTSD portion, there is a 4-point Likert scale. You don't have to worry about any copyright laws or licensing fees, as this is freely accessible to anyone online. Administering to both the child and the caregiver provides an opportunity to verify details or get a more complete picture. However, in some situations, there may not be a caregiver or one with knowledge of the child's history. You can sometimes rate a foster parent or a possible DFPS worker. Always use your best clinical judgment when you're selecting someone as the caregiver. It's important to always explain the process and to encourage them to ask questions if they would like to. Remember that asking kids about trauma does not cause trauma. However, any distress becomes evident so that clinicians can immediately meet their needs. Scoring is simple and straightforward. There needs to be at least one trauma event to move forward. Otherwise, the post-traumatic symptom scale is stopped. You will do the same process for the parent or caregiver report and also have the opportunity to look for any endorsements or discrepancies in the child's report. On the PTSS, questions 1 through 5 address the re-experiencing criteria for PTSD. Questions 6 and 7 scores avoidance. Questions 8 through 14 measure cognition changes, and 15 through 20 measures arousal, and the last 5 yes or no measures functional impairment. PTSD requires a specified number of each cluster. If a trauma event is endorsed, it is important to provide feedback such as, "I'm so sorry you went through that, you're not alone," or "Lots of kids have had experiences like that." It's an opportunity to discuss what trauma is and validate their experiences. The clinician should also address the PTSS. If moderate, you can state that even though they have experienced those traumas, they were able to cope and point out their strengths. If severe, you can remind them that even though high, it just shows it's understandable why they have been struggling. These conversations lead to discussions about treatment plan and what would work well for them. Construct validity is whether an assessment measures what it says it will measure. Reliability measures how consistent an assessment measures symptoms. Overall, the CATS is a valid and reliable screening tool to identify PTSD in children and adolescents. There has been strong research that shows that scores across different languages and samples produce consistent results, resulting in high internal consistency. The convergent validity measures if the CATS has similar findings to other PTSD scales, and it does. CAT scores also trend in the same direction as other related symptoms such as depression and anxiety, which is expected. In regards to standardized information and normative data, CATS assessments across cultures all target 2 age groups, 7 to 17 and 3 to 6. Questions are consistent and given in a self-report along with a caregiver version. All assessments follow the DSM-5 and are consistent with symptomology. So there is standardized administration and scoring. This assessment is a screening tool, so the data does not measure in percentages or rankings. It is based off of cutoff scores. There are a lot of strengths about the CATS assessment. First, it's completely free and it's easily accessible to anyone online. It only takes about 15 minutes to administer, and it can be a self-report or in an interview process. It's based on the DSM-5 criteria. It has strong validity and reliability measures, measuring trauma, exposure, and symptomology. It also has 2 assessments for 2 different age groups, which also aligns with the DSM-5. It's been used all over in places like Turkey, Uganda, Sweden, and Britain, and is available in multiple languages. The CATS has shown to be useful in both research and in clinical practices. There are some limitations to the CATS. The CATS is a screening tool and it does not diagnose. It is part of a clinical process to gather an overall picture of the client. Self-reports rely on clients understanding the question and being honest in their response. With children and adolescents, it can depend on their mood that they're in, or if they trust the person that they're talking to, or even if they can remember. Trust can be especially true with trauma victims, as sometimes they worry that if the adult didn't help them the first time, then maybe they're not going to help them now. So they don't report or they don't open up. Again, this is a clinical meeting, so rapport is very important. Providing a safe place is very important. When results are positive, there needs to be an immediate follow-up assessment. Ethical considerations. Always obtain informed consent. For the CATS, you will need consent from the child and the parent. Inform your client of confidentiality. However, any reports of abuse or neglect are mandated to be reported. Ensure the child and the adult that they understand the purpose and the nature of the assessment. Clients should feel they are in a safe and comfortable space. Use a trauma-informed approach, as questions can bring up sensitive topics. This will require the administrator to be properly trained to manage any distress caused by questions and have referral resources ready. Also, it's very important to be multiculturally competent and consider cultural meanings of trauma and symptom expressions. It's important to always provide an assessment, not only in a language the client understands, but making sure that it's appropriate for the age and ability. Although the CATS is available in multiple languages such as English, German, Norwegian, and Spanish, it's still important to remember the context from which the client is responding. Culture, family, and environment can all affect how a child will define trauma and if they feel safe to report. It's important to understand where your client comes from and keep that in mind when you're making clinical judgments. Personal insights. I've worked specifically with adolescents who come from a history of trauma and abuse for the past 10 years now, so this topic is important to me and an assessment that could definitely be used in my role now. We use the TBRI approach, and the CAT supports the need to safely identify and address trauma in children. I appreciate the ability to utilize this tool as a guide to treatment planning, but then also can continue to use it to monitor if symptoms are improving. Oftentimes, kids do not report for a while, so it's a good assessment to catch missed concerns. Psychometrically, this tool is very reliable and valid, so I'm confident in the scoring. I also like that it's free and how short it is. Kids and adolescents don't always have the patience or the attention span to answer a lot of questions and tend to answer just to be done. Also, this assessment can be used in school, counseling, mental health clinics, or private practice.